Hi, Nick. Thank you for saying hello. As people are joining, feel free to say hello via the chat. You can add your organization as well, so we have an idea of who we have in this virtual room. Thank you all. This is exciting time. We're kind of crossing the halfway point here. Great. I see a little over 30 participants. Okay, I think we can go ahead and get started. As a friendly reminder, we are recording today's session and we'll make it available within 2 business days. So welcome everyone. My name is Gabriela Gonzalez. I'm part of the EMI advisors team, and you're joining our Social Determinants of Health Data Exchange for Chronic Disease Prevention Initiative. This is our work group meeting number 6, where we will take a deeper dive and review and discuss use case number 3. For those who it might be their first time joining, we want to welcome you. We are very excited to continue with your support and engagement. Since we tend to have a large number of attendees, everyone has been muted upon entry. You will receive a recording and the slide deck within 2 business days of today's call. This work group calls are meant to be bi-directional. We really want to hear from you. We encourage you to participate in the discussion using the Zoom chat box. As you can see here, please send all of your messages to everyone. There are parts in the section throughout the presentation that we will love to get live feedback. You are welcome to raise your virtual hand and ask or share comments live. You can find the raise hand via the reactions feature. If there are any questions or any technology issues, please feel free to reach out to our colleague Savannah, who's in the background supporting today's call. And as here you can see today's agenda. We'll start with some grounding and welcoming everyone. We'll then recap the feedback received on use case 2, which was homework from our last call. We will then dive into the story and components for use case 3, and then wrap up with next steps and homework. If you have not done so, we invite you to officially join the work group as a member. You have 2 options, a committed member and other interested party. The committed member has the right to vote on deliverables. There are a total of 2 deliverables. We concluded the business case and now we're working diligently on the use case package. So committed members will be able to vote on that. So we really recommend signing up and officially showing your selecting your membership status. As you sign up, we add you to the CDC SDOH Workgroup listserv run by HL7, where we send all emails and reminders about our workgroup calls. We do know that sometimes those emails might be filtered out or marked as spam. We recommend you contacting your IT support, and if you have any of those issues, if you're not getting our emails. For any work group information, you can contact myself, Savannah or Sarah. We're part of the EMI team here to support you, and Kyla Davis, who's unfortunately not able to join us today. She is the point of contact at CDC. And we have come a long way. This was our schedule for the first 4 sessions that we have successfully completed. We are now on session number 6, June 29. As mentioned, we'll dive a little bit deeper into use case 3. So before we do that, we'll definitely recap on the feedback received on the use case 2 components and the summary of changes that have been incorporated, and then we'll dive into use case 3. As a general reminder for some of the new members, for this collaborative, the specific items are out of scope. We are not defining data exchange standards or data elements for race, ethnicity, sex, primary language, and some of the other criteria that you see on your screen, or additional as social determinants of health domains. The use cases do not directly support the use case out of scope activities are stated on our workgroup project charter. I believe Savannah might be able to share the link via the chat where you can find our workgroup charter, and it gives you a detailed overview of our schedule and really our scope and scope. We're not providing incentives for implementation of the use cases, and we're now developing a fast healthcare interoperability resource implementation guide, also known as FIRE IG. So we wanted to just remind our scope here. For some of you who are new, we definitely want to provide the background on Gravity Project. So the Gravity Project has developed 3 use cases that are primarily focused on the clinical care perspective. Some of you may be familiar, some of you are part of the National Collaborative that started back in 2019, and we are building off that wonderful foundational work that Gravity has put forward. So the use cases developed through Gravity include documentation of social determinants of health data in conjunction with a patient encounter as it relates to screening and diagnosis. The second use case focuses on documenting and tracking social determinants of health related interventions to completion, what some of us may recognize as bidirectional referrals. And then the third use case focuses on gathering and aggregating SDOH data for uses beyond the clinical care, such as quality reporting. And that's really where our work comes in. Our work group really builds off Gravity Project use case 3 and is seeking to focus on how can we reuse that SDOH data for upstream support for public health. We commend you and really thank you for your support. We have come a long way, and for anyone that would like to take a closer look into this use cases, you'll see the Gravity use case package link via the chat. For some of us who may be visual learners, here is a visual highlighting the 3 use cases with numbers 1, 2, 3, and then showcasing the coded terminology that is associated through this conceptual process. So when we talk about screening, as you can see here, LOINC panel codes are being used. For some providers on the call, this might be very familiar. For some of us who may not be providers, it's good to just have it as a reference in terms of the coded terminology that we are talking about when we talk about Gravity Project. We welcome your feedback, and here's really highlighting that we're building off that use case 3, because currently there's no use case that exists to define the upstream use of social determinants of health data for public health. To put things in perspective, I mentioned the Gravity Project has made significant strides in establishing a foundation. Some of those use cases that I mentioned are currently being piloted as we speak. The Gravity Project supports 3 work streams. One is specifically to terminology. Another one is specifically to the technical, the exchange standards to support the exchange of data from one system to another, and pilots, which are aiming to support the real world testing of those coded terminologies, as well as the use cases that I reviewed on the previous slide. What is the future? And that's where all of you come in. We as a collective are designing and will publish up to 3 priority use cases for public health. And this will expand the focus from clinical that Gravity has been really very much their bread and butter to public health, and aligning with CDC efforts to support the achievement of health equity. So we're gonna ground ourselves on, for the what is public health. In the context of this initiative, we define it as the science of protecting and improving the health of people and their communities. This work is achieved by promoting healthy lifestyles, researching disease and injury prevention, and detecting, preventing, and responding to infectious diseases and chronic disease prevention and health promotion. Some of you who may be already familiar with the 10 essential public health services, that is really our framework here. And we just wanted to touch on that as part of our welcoming remarks. And we now will start with a little bit of the work, and I will hand it over to Amy.
Good afternoon, everyone. So I'm going to just recap the use case 1 and 2 stories and personas, and then talk about the feedback that we received on use case 2. So if we can go to the next slide. So again, because we might have some new members, just briefly, I wanted to go over the stories and the personas. So in terms of personas and roles, we have Kevin, who's a care coordinator at a federally qualified health center, and Jessica, who's a case manager at the community-based organization. We have Claudia at the state health department, Claudia at the county health department, Victor at the State Health Department, and Michaela at CDC. And again, I'll come back to this, but we were limited to the number of personas we could add into this story at the time. We've had some others submitted and encourage all of you to continue to submit them for future use and future use cases. So again, the story is broken down into 3 parts, each one correlating to a use case. And so the first part of the story, or compared that relates to use case 1, really is about it starts with Kevin and Jessica, who are in the community as providers at a community health center and community-based organization, and they're seeing a rise in levels of food insecurity in their patient population, and they're worried about their patients. And they're at a meeting, and where Claudia is, it's a public health advisory meeting, and Claudia is about to embark on a community needs assessment, and she thinks that it's important for her team to be able to leverage and aggregate the social risk screening information along with the clinical and community providers information that may be conducting similar screenings, and be able to look at food insecurity, particularly for those with individuals at risk for and with diabetes. And so Claudia, really wants to get this information. She learns that the regional HIE has started to collect some of the standardized SDOH data, and most of the clinical and community providers in the county have a relationship with the HIE. And so she works it out with the HIE to be able to get some data, and she assesses it, her team assesses it for completeness and quality so that they understand where there's missing data, and to think about any bias in their analysis. And then they really want to assess the burden of food insecurity among people with or at risk for diabetes, and then look at that against information on the types of interventions and social services and programs that are already implemented for patients within the county, so that they can more specifically think about program planning and addressing SDOH needs. So that's story 1. Part 2, which focuses on data going to the state health department, is really use case 2. So I'll just talk about this, and then we'll go into the feedback we received. But for this story, part of the story, Victor is in the process of assessing state and CDC funded diabetes program, because he's in the process of including these results in a continue application for a cooperative agreement that's supported by CDC, by the Division of Diabetes Translation, with funding from there. And he wants to decrease, again, the level of food insecurity in areas in the state where there is where the burden of diabetes is highest. He also learns that the HIE has limited but some timely data on social risk, as well as some clinical data. And he acknowledges, again, it's important to understand both the resources and the needs in the community so that he can look at gaps in both, where there may be more programs or resources needed. He also initiates a partnership with the HIE, and then he's able to obtain data from the HIE, but he's statewide, so that's just a regional HIE. So he also works to get data from other clinical and community providers around social needs, particularly focusing on food insecurity. And he also supplements that with Medicaid claims data. Medicaid has some, and he overlays that aggregated data with where the state's Division of Diabetes Translation funded programs are, to really better understand the burden of diabetes and food insecurity, and then to support resource allocation. I'm not going to talk about use case 3 or the third part of the story, because Shifa will do that after I go through the feedback we received on use case 2. So next slide, please. So again, this is just another visual of the personas for the story and their roles. Next slide. And again, use case 2 components. You can see here the human actor, business actor, systems actor, and technical roles. We talked about this last time, so I'm not going to go into more depth on this. Next slide. And again, the transaction diagram, which is really showing that it's the HIE and Medicaid and then health system actors that are sending data to the state Department of Health for analysis around where there's high burden of individuals at risk for or with diabetes and food insecurity. So next slide. Okay, so about 4 members submitted comments on use case 2, and I'm just going to run through those themes and how we're trying to address them. So, and this includes both the conversation from last meeting. So some of these themes were brought up at the last meeting and some were submitted in writing afterwards. The 4 folks were submitted in writing afterwards. So during the call last time, there was some discussion about the appropriateness of using the term prevalence and need for good denominator data. And so we've removed the word prevalence and we're utilizing the term estimated burden where applicable. And please note that as I went through the stories, I went through it very quickly. So there were details that are missing that are in the written story. We will be posting that with these revisions. So if I left something out that I've addressed here, it's because I was trying to just recap promptly. We also heard last time during the call that it was suggested to broaden the story to include people at risk for diabetes, not just with diabetes. So hopefully you heard me express that as I recapped the story. So we've included that. There was a comment to add an assumption to really adjust for the amount of missing data. And so hopefully you heard me refer that in the story a little bit too, both at the county and state level. And so we've added an assumption as well that the state and county Department of Health are going to work with their clinical and community providers and the HIE to better understand where there's missing data. And that missing data could be because not every field in the SDOH screening tool was filled out. Maybe some parts were and some parts weren't, or it could be because the patient wasn't screened. Some patients in some settings may be screened, others may not, or it could be because there was no screening going on in that setting at all. So that's included now as an assumption. We also received some feedback. Again, there were some concerns that were raised regarding the applicability of the story to tribal nations. And so I'm going to turn this over to Pradeep from CDC to address that comment.
Thank you, Amy. Yeah, thank you for sharing your comments with regards to the tribal nations. We at the CDC just wanted to acknowledge that we understand the concern about the specific needs of the tribal nations being complex, and it can be an entirely new project. The conversation at this forum or work group has highlighted the need to develop other alternate workflows to address the tribal nations' needs, as well as other considerations discussed previously. So as mentioned before, CDC has been working on advances in tribal data elements standardization. They are directly supporting the US CDI version 3 on the tribal affiliation data elements, and we are working to hopefully invite a subject matter expert or subject matter experts to discuss these efforts at an upcoming work group meeting. Thank you, Amy.
Thank you, Pradeep. Okay, next slide, please. So continuing with the feedback, there was a suggestion to add a community health worker. And also at the last call, there was some discussion about payers also have some social determinants of health data. So again, we encourage all of you, whether it's a community health worker or a payer or others, to submit your personas via the persona worksheet, which we can address again and show you how to get there at the end of the call. There was a suggestion to clarify that the standardized SDOH screening tool be adopted, that a standardized SDOH screening tool be adopted by all clinical and community providers that are part of the HIE. And for this comment, we wanted to point out that the Gravity project, which is for which we're basing sort of the use case for around public health, is really agnostic to the screening tools. And the data capture systems. So we have an assumption that really states that the clinical and community providers can send the SDOH data in a standardized format using the Gravity code sets, but we didn't think that it was realistic to say that there would just be one standardized tool that everyone that works with the HIE would be using. The next comment really related to clarifying that food insecurity is not just about having sufficient food or not, but it's also about sort of the quality of the food and having access to healthy food. And so we just want to point out here in response to this comment that the value sets for the Gravity project for food insecurity, we've shared a link, but there's a number of different in the value sets. It doesn't just focus on insufficient food or the inability to pay for food. It focuses on other things, and we've given you an example here. For instance, there's a diagnosis code that says nutrition is impaired due to limited access to healthy food. So again, it's not just limited to whether there's sufficient food for the individual or not. Next slide, please. There was some concern that not all screening tools support the Gravity project standards, and that some screening tools have individually developed questions that are put into screening tools, and that the responses are actually text-based and not standardized, and it would be difficult to send all of this to the HIE. And we understand that this is a known issue. So we have modified the assumption modified an assumption to indicate that there are common screening tools, questions and responses and interventions that have been mapped to the Gravity project, and that the various actors in the story, Victor and others, will work to assess which questions are not mapped and to understand why, and then to work with the stakeholders to develop a plan to address that. There was also a concern about the lack of widespread use of Z codes, and that it's important to have more use of that for uniform documentation for healthcare providers. And that we felt was best addressed in including in the recommendations that will be coming in the final report that we will be submitting to CDC. And I believe the last comment received was related to a question regarding whether the state health department has access to aggregated data collected by the county Department of Health for either the purpose of a community health needs assessment or actually for other purposes. And that we wanted to discuss with you a bit further. So next slide. So that was the feedback and how we plan to incorporate it. But on that last point, we wanted to just open it up for a little bit of discussion and ask the group to share with us your understanding of how much data sharing occurs between local and county health departments and their respective state health departments. What type of data is being shared and for what purposes. So if anyone has any thoughts on this, please feel free to respond either in chat or raise your hand. Okay, Lori.
Well, I'm sorry, but something occurred to me as I was reviewing the materials for this meeting. So I had a quick comment before we move to this, if that's okay.
Sure.
It's regarding the transaction diagram. And so this didn't strike me when I was first looking through it to provide the feedback ahead of time. But with the direction of data flow, we could have data coming from the health system to the HIE, which is going to go to the state health department. So it's almost like we might need to have another arrow showing that there's two ways it might come from the health system. Yeah, so I think if I've heard you correctly, use case 1 shows, I believe, what you're expressing, which was that the clinical and community-based providers are sending data to the HIE, and the HIE was then sending on to the county. And I believe under, Gabby, if you can just go back to the transaction diagram for use case 2. So here we have health systems, which is meant to be those
wait, I got to make my screen a little bit bigger here, which is meant to be clinical and community-based providers plus the regional HIE. But what you're, and because the regional HIE would, in the previous use case, has data coming into it. We didn't take all the transaction diagrams and make one long one with all the use cases together. So does that address your comment, or?
It does, but I think that it's probably true for both use cases, whether we're talking about, you know, the individual, I don't, it just feels like that the data flows both ways, and it and would be more clear. But if there is a distinction, then maybe I'm missing that between the two use cases.
Amy,
So go ahead, Sheetal.
Oh, yeah, I was just going to chime in, Lori. So, yeah, totally get that the health system could also be sending to an HIE. In the story, though, for use case 2, we, you know, Victor, right, he's sitting at the state level. And in our story, we had, you know, the regional HIE as a trusted intermediary only is connected to a majority of providers in a specific region of the state. So from a transactions perspective, we wanted to show that the data could be directly coming from a health system as well as another regional HIE, because not all the providers in the state might be connected to that HIE. So that's just the context of the story, but completely agree that, you know, in use case 1, you could also have, right, like the data coming directly from a health system, or the health system sending it to that trusted intermediary that then passes it to the health department. Does that make sense?
It does. It does. You're distinguishing between this regional HIE and the health systems that may not be a part of.
Exactly. Yeah.
Okay. Thank you. And I'm sorry. I should have.
No, I apologize.
In that case, should we plan for duplication, or be aware that they may be coming in from same data, may be coming in from HIE as well as from healthcare provider? Is that a possibility?
For this use case, Asha, you were talking about for this use case?
Yes.
Yes, so I think health system here is meant to be the clinical providers that are not attached, that are not sending data to the HIE. So we have a regional HIE, which has a bunch of clinical providers that are, and community-based providers that are sending to a regional HIE. And that regional HIE is sending on to the state. We also have other individuals in the state that are not part of the regional HIE that are sending to the state. And then we have Medicaid that is sending to the state. So
Sure.
Does that address your question, or were you suggesting another change?
So we're basically saying that the health care providers would be freestanding and the ones that are not attached to HIEs. Okay,
Yeah.
I get it.
Asha, I'm thinking though, yeah, Amy and Asha, though, I'm thinking it's not a bad assumption, though, to put it in the story in case there are duplicate records, right? They're going to have to account for that. So I think we can still add something to that extent, Asha.
Right, and we may just, I mean, what I'm getting from this conversation is we may want to broaden what we have in the transaction diagram from health system to a broader term of providers, clinical providers or something, but we can take that back. So appreciate that, Asha.
Okay, thank you.
Okay, so we're going to go, any other comments in general about this?
Comment from Jim in the chat.
Yes, okay. So Jim, do you want to elaborate on that a little bit?
I'd be happy to, and I will try and be concise in my comments. We have two stakeholder groups within Linux Foundation Public Health, a Public Health Advisory Council, and the Disease Investigative Technology Collaborative, fancy name, that grew out of COVID response, pandemic surveillance efforts, so forth and so on. We had our meeting yesterday and have about 34 representatives from state and local PHAs that are involved, including a couple organizations that are on the call today, and reps from CDC. And a couple of things that came out thematically. It's all non-disclosure and not for attribution, so I won't name any names. But for instance, using COVID as an example, we had a county health representative who said they were still reporting COVID statistics at the county level to the state, and the state basically said, we don't care, we're not collecting them anymore. Another big thing that came up was challenges around race and ethnicity data. and particular county organizations and state organizations on the call who mentioned that their HIEs don't reliably report race and ethnicity data, which causes concerns about population health and patient matching type information. And then lastly was just the variation in systems, which we're actually going to be working with CSTE on a landscape report they're going to do on the variety of systems being used. Some states can still afford to use Salesforce, some can't. Some have homegrown systems, some don't. Some use consortium models for others for data. But it's definitely an area where consideration for fire and for the Gravity Project, of course, is excellent. But there are secondary and tertiary considerations for interoperability and data sets beyond just fire-based data sets too, which will come up for conversation. So it's a rich area to explore, I would offer.
Great, thank you, Jim. And I see Gia, you have your hand up.
Yes, I think one recommendation to keep in mind is if we could provide them with sample data use agreements, it tends to help that relationship out a little better. And what language should be in that data use agreement. And oftentimes we feel that when we share sample language for data use agreements, it facilitates that relationship with the state and the local and county level more specifically, or it helps a little better.
Great suggestion. Thank you. So any other thoughts on this topic? And I think part of this was again spawned by the question about whether state public health departments have access to aggregated data collected by county or other local public health jurisdictions, and what those scenarios were, because we sort of made the assumption that we haven't necessarily plugged in the county feeding into the state here in the story. Okay, Gia.
So we often get state data that is aggregated that includes their local and county and any other recipients that they're subfunding. So oftentimes the data is reported to the state in an aggregate. And that actually in this case isn't helpful because they can't disaggregate it and identify additional nuances, or it doesn't allow them to stratify the data across multiple counties and across the whole state because it's one aggregate number. So it's actually better for them to report it disaggregated. And then in this use case scenario, if the state is using this data to make statewide decisions, if it's already aggregated and it's not stratified the same or collected the same in those different buckets, then it's hard for them to put it together and then make decisions.
Okay, thank you for that. All right, any other comments on this topic? If not, we will move along.
Sorry, I'm late to the call. Apologize. I just jumped off another call. I apologize.
That's okay.
But I'm only could be on for a half hour and I have to jump on another call. So I apologize. Hi, Katie Weber. So this is one of the critical things we're actually working right now in California, is really trying to create the data exchange standards. And you may have already talked about this. So I apologize if I'm repeating myself. So it's really important right now because we're working on the waiver, CalAIM waiver out here in California. So we're actually looking at population health strategies. So this is going to become very, very, very important as we share between public health, healthcare, the social service agencies, and our CDA organizations. So the type of data is being shared. There's a lot of SDOH data being shared. We're trying to align SDOH with healthcare data because we're rolling out the community supports, which is our we finally integrating social services into our managed Medicaid out here. So as these gets more and more mainstream in other states, I think this is becoming much more critical in this piece, and also aligning. That's why it's not an HIE strategy necessarily. That's why I kind of like the word HIE, and that's why we taken that politicalness out of it, but more of the ability to exchange data between your social service agencies, including CBOs, including your government agencies, to be able to have that exchange of data. So that's why I really like about the Gravity Project is really aligning that mapping piece around that piece, because you don't, or not necessarily gonna get standardized questionnaires, but if we can code them accordingly, then that will help kind of align that from a coding perspective and also from an outcomes perspective and population health strategy. And you've probably already mentioned that, but before we move on, that's kind of where my feedback. So I apologize if I repeated anything you guys just done, but that's kind of that perspective. So
yeah, no, and thank you for your comments. And we did just go over, and you can see the slide deck if you didn't see where your comments were included, and and our response to your comments. And just one last comment on the use of HIE. In the story, we use the HIE as the human actor, but we really, as the technical actor, we really try to use a trusted intermediary, and we've aligned that with the MedMorph, I think it was MedMorph language. So you will see both trusted intermediary in some parts and HIE as an example of a trusted intermediary.
And I might, that's why I would put like, yeah, definitely trusted intermediaries top, and then put HIE as kind of parentheses or because that's kind of, because that gets very political. I've been in those meeting rooms before when they tried to bring HIE into certain areas. So that's why, to avoid the politicalness around this, but in order to keep it moving forward, I would put, like you said, the data, more of a data exchange perspective versus an HIE, because then everybody gets hung up on the HIE and loses the end goal from a political perspective.
Great. And I see we do have a couple of comments in chat. And Heidi, I think you were commenting that, again, the challenge with HIE, or maybe perhaps any trusted intermediary with low quality race and ethnicity data, is in the collection from the healthcare provider, and the patient disclosure is spotty in that regard. And I think that's an area we all know is a challenge to be working on. And Gia, I see you put in a comment. Do you want to address your comment as well here?
I think from the standpoint that I believe she was just making about using that language of data exchange versus HIE. The Cody project might provide some good examples of how they address that, from collecting data from community-based organizations, including it in their data exchange, so that they don't push away that community-based exchange piece, because when we think about bidirectional, we need all parties engaged at the table, not just the health information exchange.
Great, thank you. And Julia, I see you have your hand up.
Yeah, I was just going to say, I think I've learned a great deal about this from organizations that work across state and county lines. So, a lot of the public health data sharing, I think, is a black box to many, and the level of effort it takes to cross over these jurisdictions is quite significant. Not only is it a black box in terms of what's happening to data after they get it, but also the requirements are very difficult to understand, and usually there's a very steep curve that's required to actually configure and get to the place that data sharing is really done. I mean, I don't think anyone on earth has any idea exactly how much attempted data exchanges are happening and how much that data is actually received and utilized for anything. I think the assumption is that a massive amount of that data is, quote, exchanged or sent, and nothing ever happens to it. It's not either able to be read, or it's not used. It's not made right access, or it's not given right access. So I think it's something to think about. Like, can we make sure that our use cases ensure some kind of bidirectionality and insurance of the receipt of data and information about what happens to it as part of the process, because there's not really accountability in the interoperability space. And I often hear people tout these numbers of exchanges that they make, and I don't think that those numbers are realistic when it comes to the meaningful use of data. So I think that actually should be a caveat for us. Like, are we people just sending tons of data all the time to God knows where and God knows what's doing with it? I think that's kind of the case in some instances. And I appreciate the comment about, thinking about CBOs, because, healthcare organizations have had a much longer period of time to think about privacy and security issues, and they still struggle massively with it. So the idea that an organization whose primary mission and legal responsibility in this area is unclear and their expertise is limited, that they'll be successful by sheer luck is pretty low. And so I think as we're sort of reaching across the aisle from healthcare to social needs organizations, that we try to extend our knowledge and best practices to them.
Great points, thank you. And we can think about your comments around sort of the receipt of data and stuff in terms of some assumptions and think about how to perhaps work that in. Appreciate all your thoughts and comments.
I'll end with the alignment, because to start back to the beginning of my point, which I hopefully ended up getting to. Yeah, the burden on the people who are trying to share data with multiple organizations is exponentially goes up the more organizations they add. And it shouldn't be like that. It should be you invest a lot of time getting it right the first time, and then you can share your data with lots of organizations. But it's actually the opposite. Everything is a one and done kind of thing with the added burden of maintenance of that one connection. So the more you want to share and be interoperable, the more effort that goes into it constantly. And that's sucking value out of the other work that we're doing to invest in.
Yes.
So harmonize, harmonize, harmonize.
And hence the reason for the use case in this work group. And with that, I think I'm going to turn this over to Sheetal to take us into use case 3, unless there are any other burning questions. All right, Sheetal. Thank you all.
Yeah, thanks, Amy, and thanks everyone for this really valuable discussion and feedback. And so if we go to the next slide, please. So again, some of these slides will be repetitive to some folks, so apologize for that. But in case folks are new or would benefit from a bit of a refresher, we're just going to walk through some of the slides that will help kind of frame the conversation and the questions that we'd love for you all to be thinking about as we walk through part 3 of the story, as well as the use case components. So, before we dive in, wanting folks to think about, just having these questions in the back of your mind, are what we're talking about with these, the story and the use cases, are they meeting the needs of public health professionals? Is it providing a compelling reason to leverage the data? And is this something that can help us drive towards a desired future state? And again, we want to acknowledge that a lot of the assumptions and the context that we provide in the story, we know is not reflective of a current state, but we're hopeful that by aligning together and developing a story and its use case components, that it helps collectively drive the ecosystem together towards more alignment and harmonization. And so we'll come back to these questions at the end, but always, again, feel free to put your questions in the chat, or you can unmute yourself, raise your hand, and Amy and others will chime in. Feel free to interrupt me if you want to stop and pause for someone's questions and comments. Great. And so the next slide here, and apologize, I know this is a lot of words on a slide, but just to give you the recap of, the part 3 of our story here really focuses more on Michaela. And Michaela is a project officer at the CDC. And just to remind folks, when we first, embarked on this work group process, we did develop personas and roles. And, with Michaela, just to remind you a little bit about her, she loves to work with her awardees on implementing public health programs across the United States. She recognizes the importance of establishing the performance and outcomes measures to help achieve those goals. Given the diversity of her awardees, it's sometimes challenging for her to make recommendations about, available social services, programs, and resources at the community level. And the CDC doesn't have necessarily all that granular level data across all the SDOH domains to help guide program decisions and identify the needed resources to support all of their awardees. And part of her goals are that she wants to help her awardees be successful, help disseminate best practices, and facilitate those meaningful peer-to-peer connections that will ultimately help reduce health disparities among those who are at risk for or diagnosed with diabetes. And so with this part of the story, we have Michaela, who is the project officer for Victor's state, and they often touch base face as they would to discuss the program, as well as sharing, promising practices in the field. And so through these regular check-ins and conversation, Victor tells Michaela of the work that, he's led in terms of the analysis around the SDOH related data that leverage the clinical, community, and claims data to better understand the burden of food insecurity among people with or at risk for diabetes in a state. And part of Michaela's, role again is wanting to ensure that these best practices, as well as, working with her awardees, are leveraging data to the best of their ability to assess and monitor their programs, again, based on the CDC cooperative agreement requirements. And as a division, the Division of Diabetes Translation, or DDT is the acronym we'll say, is encouraging all its awardees that are implementing these food insecurity strategies to track and report the number of individuals with diabetes, by demographic factors such as race and ethnicity, and who have been identified with food insecurity as a social risk factor, wanting them to set target goals to help reduce household or food insecurity. And I just want to note that this is also information that's based on some internal work that the CDC is conducting related to developing a framework for SDOH measures and guidance. And then just to quickly move on, there is also, wanting to ensure that, as it might not be in the current state right now, but that the CDC is wanting to specify outcomes measures and associated data sources for their 5 priority SDOH areas, and that this would be intended for use in routine grantee data reporting to help monitor progress and demonstrate the impact of these programmatic investments. And so Michaela, as a project officer, is providing technical assistance and support to her awardees to assess these activities that support diabetes prevention and management, and really help understand the data that the awardees are working on, or sorry, the strategies and investments that the awardees are working on, by also reporting on the individual and community level social risks associated with health outcomes. And so in our story, we later on say that when she receives these reports, she and the DDT team analyzes the data to help assess awardees' progress towards their targets. They help try to assess population trends, identify innovative practices, and disseminate the data to all awardees, national partners, and leadership to help inform data-driven decisions. And I just want to pause here, and I want to thank Gia from the Division of Diabetes Translation, who's really helped given us a lot of guidance and feedback on this story. And Gia, I just want to give you the floor for a moment if you'd like to talk a little bit more about the work that you're involved in related to this.
So as we talk about this use case scenario, we do want to say that this is a hypothetical story, but it aligns a lot with what the work that we're doing. So our center in 2020, the National Center for Chronic Disease Prevention and Health Promotion, pulled together a tiger team to develop a SDOH framework that consists of SDOH and health equity SMEs across our whole center. So everyone from Division of Reproductive Health, Division of Heart Disease and Stroke Prevention, DNPAL, all of our divisions had representatives on this tiger team to develop this framework that I dropped in the chat box. This framework does not address all SDOHs, just the priority ones that most aligned across all of our divisions, that we could come up with a consistent aligned group of topics. So built environment, community clinical linkages, food and nutrition security, social connectedness, and tobacco-free policies. Within that framework, we identified activities to recommend to put in future NOFOs, and we also developed cross-center performance measures to support all those strategies and activities. So this is very much a story that represents kind of the process that we go through to ensure and moving forward that SDOH is represented in our NOFOs. I'm also going to drop in a link to our current funded programs that have SDOH related strategies in our NOFO. So DP 18-18-15, which is improving the health of Americans through prevention and management of diabetes, heart disease, and stroke, is a joint NOFO that DDT and the Division of Heart Disease and Stroke sit on together. And one of our strategies, just for example, so you can understand that fall under community clinical linkages, has to do with CHWs and other community-based providers to help individuals to participate in evidence-based lifestyle change programs. We also have 2 strategies that fall within that community clinical linkage activity. And that's our pharmacy strategy, which I'll put a link to our page as well. And our link to our CHW sustainability strategy. For our 18-17 NOFO, which is also a sister NOFO to this NOFO, looking at more innovative practices, we have a strategy that aligns with this story as well. It's specifically implementing systems to support bidirectional e-referrals between healthcare systems and CDC related lifestyle change programs. So just some context to see, I'll put in the link, how our program NOFOs and how our strategies are worded and the type of activities within those strategies align with these use case scenarios. Because for every strategy we do have performance measures that support these, that require us to do data aggregation and assess population trends. And do just what this last bullet says. It helps us identify innovative practices, which we then scale in our future NOFOs. So I'll pause there for questions, and I will put the link in to our state and local and nationally funded programs if you want to take a quick closer look and see how some of those strategies that we already are funding are in our current NOFOs.
Great. Thanks so much, Gia. Any questions from the work group members? Well, please feel free to, as you're maybe thinking or processing, if you have any questions, feel free to put them in the chat and we will be happy to circle back to them. And Gia, again, thank you so much for your support with this work and project. So thank you. If we go to the next slide. Okay, great. Thanks, Gabby. So I'll just move us along here regarding the use case package. Again, apologize for being repetitive, but as Gabby mentioned earlier, the use case package is going to be the output of this work group. And highlighted in red are the areas that we'll discuss today regarding the specific use case components. If we go to the next slide, before we dive into those components, just want to quickly ground and level set with folks on the line about what the definitions are. And so hopefully, you can see on the screen, I won't go through all of them word for word, but you see use cases, we have the actors, and again, the actors, we'll go over the human actors, the business actors, which in this case will be the awardees that DDT funds, which include state, territorial, local, and tribal health departments, national associations, tribal organizations, and others, and then also the system actors. The assumptions, again, in the context of this work, just helps us as a group collectively identify, what do we want to assume as we are developing this story, and this could be related to policy or process, anything that we collectively want to state up front. And again, knowing that some of the assumptions certainly do not reflect the current state, but just help us as we're defining the transactions. If we go to the next slide, the preconditions, slightly different in that they describe what must be in place just from a systems perspective. The transactions specify that the data exchange between the systems, the message content, will describe a little bit more about the data types and the categories of data being exchanged. The post conditions help us just describe the state of the system as a result of what is exchanged. And then lastly, the alternative flows help us describe other types of scenarios that could result in the user completing the goal. And so in this case, for this project and our use case components, we'll want to acknowledge that there's many, different information sources or different intermediaries that could support this data exchange. So we'll keep, some verbiage around that. And so with that, I thought we could, again, as we've done before in the past, walk through use case 3 components. So Gabby, I'll share my screen. Thank you. And just walk through now in the context of use case 3, each of these areas. So again, with the actors, you can see the table here that has the human actor, the business actor, the system actor, and their technical role. And again, in the context of this story, we're gonna basically highlight 2 types of program awardees, but this obviously doesn't represent, the world of awardees, but we've chosen for this one just to be reflective of the types of different organizations that DDT does award. One is a national association, and the other would be a state, tribal, local, or territorial health department. And then the information recipient in this case would be the Division of Diabetes Translation. And here are their correlated system and technical rules. And then with the assumptions for this part of the story in this use case, so we do mention here again, the division awards a variety of different types of organizations ranging from state and local health departments, national organizations, tribes and tribal serving organizations, as well as US territories and freely associated states in the Caribbean and the Pacific. So a very diverse set of awardees. These program awardees can also be funded through different opportunities. Some of which Gia mentioned that are like the National Diabetes Prevention Program and other programs and cooperative agreements that help prevent or delay the onset of diabetes and help improve health outcomes for those diagnosed with diabetes and prevention activities related to diabetes, as well as obesity, heart disease, and stroke. And as we heard before, we know the CDC wants the ability to help to collect that individual line level data from awardees related to those recommended SDOH performance measures. Again, this doesn't happen in the current state, but it's a desired future state. So for the purpose of the story, we wanted to acknowledge that desire in the assumptions. And then similar to our previous use cases, again, this work is focused on trying to leverage structured coded data related to SDOH screening, diagnosis, goals, and interventions. So we do say that the awardees are using nationally recognized terminologies defined under the Gravity Project. And then lastly, we have the program awardees that distribute funding. Yeah, we just wanted to acknowledge, with the second to last bullet, that some program awardees are distributing funding to other organizations. So just to acknowledge that in that case, those organizations will also aggregate this data in alignment with the program reporting requirements. And that the last one then is that all of this information is shared and accessed in accordance and compliance with the appropriate federal and state privacy, security laws and regulations. So we've stated those assumptions up front, and feel free to chat in or raise your hand if you have any questions. Or if we've missed anything, certainly want to make sure we're covering all the bases here and that it's clear to the readers of these use case packages. The preconditions then, just switching gears to that, is the information centers, which in this case is our program awardees, have the data repository that can capture, aggregate, and send this data for program monitoring and evaluation purposes. The information recipient, which is the Division of Diabetes Translation, has a data repository that can accept this data from its program awardees. And lastly, that the information recipient does have the analytical tools that can overlay this data with other tools and GIS mapping tools. And then in the transaction, similar to the previous ones, we have sending aggregated SDOH data in a standard format. We have the message content, which describes that this data will include the categories of, but is not limited to, the screening questions and responses, interventions and diagnoses. Then in the post conditions, the information recipient is able to accept, analyze, and then act on this data. And then here in our alternate flows, which has come up before in our conversation, and this is where, again, we'd love to get your feedback. We know that, it's an evolving landscape, and there's such diversity across all of these different organizations and how they're partnering and working with other sites or other organizations to support the implementation of these programs. So we say that this can include, like, some of the other examples of data information sources, as well as in organizations that may be aggregating and then sending this data to others. It could be directly from healthcare payers. We have an evolving landscape with community information exchanges. We also have community-based resource platform vendors, care coordination platform vendors, and other providers' IT system. There's just a really broad diversity across the social care and healthcare ecosystem, with great work that's being done in the field. And so want to ensure we're trying to capture the diversity in these potential scenarios and the alternate flows. And then just acknowledging that these actors could play dual roles of information sources as well as intermediaries. And then this came, the last section here just came also from feedback in a previous work group conversation around, the potential of utilizing privacy preserving record linkage, PPRL, which is the means of connecting records using a secure process. And so we wanted to also keep that in here as a potential alternate flow, even though we specifically have decided not to specify whether or not the data being sent is identified or de-identified for this purpose. And so I will just scroll down now to the very last section of the use case components package, which is our transaction diagram. So you'll see here we have the National Association, as well as the STLT Health Department is our information source. They could also be data aggregators, and they are the data sender. And so we have them sending data to the division, to support the program monitoring and tracking of those performance measures, as stated earlier. So I'll pause here and see if there's any questions, and if folks would like me to scroll up, or feel free to let us know. So pause here and see if there's any questions.
Sheethal, there was a question in chat a while ago about whether there's a viewpoint on computing return on investment, and another comment saying it was a great comment to make or question to ask. So.
Oh, great. And Sabby, would you like to just elaborate more on your question?
Yes, sure. Thanks for taking the question. So primarily what's happening is, like, I work in Duke, and so we're trying to, we're trying to work with CBOs in terms of, like, adopting the NCK360 platform, right? And part of that conversation is I think what we see is, like, there is not much adoption, and the ROI component comes up, like, okay, why should I be investing? Because from, like, a provider point of view. And so we are trying to, we sometimes struggle because there's so many ways. And one of the things we hear from people is, like, compute it from a social impact point of view, right? I mean, there is a bucket, use something as a financial proxy and try to compute numbers. We're trying to work backwards, right? Okay, if this is the investment we do, and this is a social impact. So that is a bucket where people can eventually play with, whether it's, like, from a, value-based care, ACO point of view, or whatever that is. So we're struggling to figure out, like, okay, how do you, showcase ROI to the people who are going to eventually fund it? And so that's a basic question we hear. And that's why I was just curious, like, is there, you guys have, like, any point of view on that? So.
Great. Thank you so much for the question. I know we have a lot of folks on the line who probably have similar questions and might have experience or resources. I want to defer to the other work group members first, Savvy, and see if they have anything that they want to share with us first on that.
This is Art Davidson. I don't know that I have a direct comment on ROI. That's a wonderful question and worthy of a lot of discussion. So I'm not really prepared to comment on that, but I would just make a little comment on this transaction diagram I intimated earlier to the group in a response. You know, the model that you have here is based on who gets funding. Right? This is the way that CDC looks at its funded, the awardees. But really, you shouldn't, you should look at this more as if, what are the sources of data and how will it track to the CDC, rather than, I only have control over the people who have funding. They have relationships with others. You know, the National Association, the example that I think we might look at is the digital bridge, and the APHL was critical in being able to receive all the COVID reports. So here's a national association that set up a platform to receive information that was valuable to CDC, that, you know, the states didn't have to set it up, but they were sending the data back to the states as well as to CDC. And it was connected to the hospitals. So I think the diagram is a little bit simplistic, or even assumes a certain final configuration based on a funding stream, which is not what we shouldn't base it on the funding stream. We should base it on operations and practical, pragmatic approaches that would have better return on investment.
Awesome. Thank you so much, Art, for that feedback. Yeah, it looks like we got folks in the chat that agree. So, and yeah, Amy, I don't know if you have any thoughts or reflections. I'm just trying to think of like, okay, great. How can we reflect that better, Art, your comments? How can we reflect that in the document?
Yeah, and Sheila, I want to say, when we were doing the story and even thinking about this, I think one of the reasons we relied on program awardees is because there was a contractual relationship. And since there are no sort of universal policy levers or ability to sort of, I don't want to say require screening, but to sort of push the aggregation and push the screening and the aggregation of it, we felt that from a use case perspective, trying to see where there was actual leverage to be able to get the data was the best way to go. But we totally hear what you're saying. And, you know, clearly in the example you gave with COVID, there was not well, I don't know if, you know, what the reporting requirements sort of really were or weren't in depth, but there was a clear urgent need to do it, which might have driven the value of doing it a little bit more. So, you know, totally agree with what you're saying and appreciate your thoughts. And so do many, as I see here, lots of people in the chat are really appreciating what you said. And if you have suggestions or others, we'll take it back and mull this over and think about how to reflect it better. But if you also have suggestions on that, you know, certainly let us know. And we really do appreciate the feedback and all the comments in chat. But that is part of the rationale of why we were somewhat limiting to program awardees, because we knew that there may be that leverage between the funding and knowing that there's much more going on out there that would be important in terms of data to collect and aggregate and use and look at.
No argument. No argument at all. I understand why CDC and the division would be looking at, and you would leave it this way. But we also have the power of HL7, you know, the gravity work, which is not about awardees. It's about a community and consensus. So, you know, certainly we want to be respectful and acknowledge what are CDC's requirements here, but also to recognize the power of what gravity has done so far.
Yes, thank you.
Thank you so much, Art. And then I know Heidi sounds like has a comment. Yeah, Heidi, would you mind elaborating on that? Your comment in the chat?
Sure. I mean, this is a much bigger scale than what we've been discussing in the Houston region, but looking at, you know, having different levels of engagement in data sharing ecosystems, and having one level be those who are funded, and then having another level for those who are not funded but have data to share and would have some benefit from participating in a broader ecosystem of having their data aggregated or access to some of the aggregate reports, et cetera. So that I think there's ways to incentivize that type of data sharing. Totally agree. Leveraging the HL7 and other collaborations is an opportunity worth thinking through.
Thanks so much, Heidi. Appreciate that. Definitely. Other thoughts or reflections? Yes, and Nikolai, I'm going to ask you if you mind elaborating too on your comment that you just put in the chat.
Good afternoon. Do you hear me?
It's a little bit breaking up, but you want?
I will try my best.
Okay.
So I do understand this is diabetes use case, but I want to remind you that for many other programs in chronic diseases, other centers, we have two-way actually data exchange. And as example is when we send aggregated data from states to CDC, then CDC make aggregated picture and share with all states and awardees and so on. This is just one example when CDC shared back information. That's why my suggestion is to make two ways communication data exchange here. Thank you.
Great. Thanks so much, Nikolai. And yeah, I think, and then Amy, feel free to chime in too. I'll tell a little bit about the thought process. Was that in the story, we did want to acknowledge that the CDC does share the analysis or results of what the awardees were reporting, you know, via, it could be, reports or maps, but we didn't have an actual transaction that showed the data that they collected, aggregated and being sent it back from a transaction perspective. Amy, I don't know if you want to state that any other way. I'm not sure if that was like clear, but that's in mind.
Yeah, I mean, I think the transaction diagrams and even in the use case, it's very specific to what data. I mean, it's not, we're not super calling out data elements, but we're sort of saying, okay, screening data, you know, is going, you know, from one place to another. And so if, unless we're misunderstanding you, if what you're saying is sort of taking the data that CDC gets rolled up and then sort of benchmarking a state against another and making that publicly available or back to the states, that's what I think Sheethal was sort of referring to. If you're suggesting actually taking, you know, other data that may be coming from other places in the state and sending it to the state that they might not already have, like screening results or diagnosis or something, that's something different, but I'm not quite sure that's what I thought you were saying. So if you could clarify, that would help us a little bit. But as Sheethal said, from the point of view of sharing back with the states, either accessing it through, you know, some sort of public portal to look at state rates or things like that, that's sort of a little bit, or a report with various state information, that's sort of different than the way the use case has been built, if I'm being clear. I don't know if that helps at all.
It does help. It does help, absolutely. I mean, I agree with you. And you're asking about specific examples. I'm trying immediately to find something. So one of these examples could be community vulnerability index, something like that. So we calculated here and then share with RDs and other states, and we can see how diabetes problem is related to SDOH through these indices, this or many other indices. So this is one of the ways, just on the fly, I'm trying to think how to describe it.
Okay. Thanks, Nikolai. And I think what we can do after the call is let's go look back at the story, and then also just see, Nikolai, if there's like other specific examples that would be valuable to include that are reflective of CDC and DDT. Maybe that's something we can think about how to massage back into the story. And I know it's been a theme from Ray and others on the work group that, the value for public health is to also share back this analysis and information with its stakeholders to support community health and improvement. And so, if we can bake that more into the story and make it more compelling, and even potentially have a transaction that really does that, I think it'll just make the story a lot more valuable, hopefully. So we'll follow up with you offline too, if that's okay. And then I see Julia says, agree with Heidi, you need to have some kind of DUA if there is identified data or a limited data set. Okay, yeah, we can go back and then just make sure that's clear. Sabi, I'm sorry, you had a question. I know Dorothy responded in the chat going back to the ROI, and then you just submitted another one. But Sabi, I just want to circle back to your question. And in the public health business case that we developed, which was the first deliverable as part of this work group, we have a section that relates to anticipated return on investments. And our research that we did in developing that deliverable, and if Gabby or Savannah wouldn't mind putting in the chat, we really looked at what healthcare payers looked at from an ROI perspective. And I know you talked about social impact and different buckets of looking at ROI, but I just wanted to point you to that resource for now. And then hopefully if others on the line can share their expertise with you, would love to hear more about that as well. And then your question in the chat, how does private enterprises like Unitas play in these flows? And I don't know if Toby, I saw you were on the line. I don't know if someone from Unitas is also on the line, but would you kind of like to share some of the roles or the work or how you envision yourself in supporting these types of use cases?
Hey, well, this is Brian Stone here, Vice President of Federal here at Unitas. And so naturally, I mean, there's a lot of great ideas and insights that are being brought forward here. And, when we look at specifically to the questions about ROI, I mean, we're always trying to really be a part of is like reducing, ED visits, right? Increasing access to food and resources and other measures, and obviously the financial impacts associated with work for case managers, right? So we look at everything from the financial savings that can be brought forward by beginning to measure SDOH and having insights and improving discharge processes, and obviously increasing connection to services, right? So there's a whole host of resources and insights that we want to bring forward. And again, this, for many of us, I mean, this is clearly a mission. I mean, we've been around for a long time and we've been at this work for a long time. And I remember as growing up myself, before SDOH was actually an SDOH thing, it was also always about what resources you had available when you were growing up in the South and like how close you were to access to education and resources and the like. And so, for us, it's really along those lines. I think that there is so much that we can do there. We want to be able to collaborate as much as we can. We want to be able to work in concert with state governments and the resources that are there. And we appreciate the guidance and the insight and the framework that's being brought forward here with the CDC, particularly with chronic disease prevention and the like. So, I mean, I think that, for the sake of this conversation, we want to be able to provide more detailed insight that others are probably much more versed to do so, right? I wish some of my other patriots on my team were attending this. They can provide more insights from interoperability and the like. But I'll just raise that up here. Hopefully that's kind of helpful.
And Sheethel, I would just add from, I think from a comment I made before in terms of how, some of the private enterprises play in here, to the extent that we're talking about trusted intermediaries as a way to aggregate some of this data to then be able to share with public health on behalf of whoever their client, is. Again, for this story, we use the example in term HIE, and someone, mentioned that before, but I think that we have said in terms of the, that it's really, we're really talking about a trusted intermediary. So where there's an HIE, it could, it can also be phrased in, in the transaction diagrams, it is as a trusted intermediary. So something like a community health information exchange that is based off some of Unite Us or other platforms could be considered a trusted intermediary and another way to get aggregated data. And I think there's some more comments in chat, but I just wanted to throw that out there and clarify that again.
No, fully agree. I agree with that 100%. Absolutely.
Thank you, Brian. Thank you so much for that response. And Sabby, hopefully that helped clarify a bit. And then Lorene, thank you so much. Lorene, would you like to verbally share a little bit more?
Yes, sure. So I'm at Stanford University School of Medicine and Stanford Center for Population Health Sciences, and we have a longstanding partnership with Solano County Public Health. It's one of the 58 counties in California, and we've set up both DUAs for sort of limited data type agreements that are de-identified, fully de-identified, and we also have a BAA that we can use when we're kind of acting as an arm of the Solano Public Health Department. They're allowed to share those kinds of data with us. It's not for research purposes, it's for their own, operations and so on. So I was just going to offer, if there's anybody planning the same thing, if they'd like to see our DUAs and BAAs and the sort of scope of work, I'd be happy to share those.
Maureen, thank you so much for that that offer, and I hope folks, if they can't see in the chat, there's your email address. That's wonderful, and I'm sure people would find that really valuable. So thank you so much for that offer, and excited to hear certainly more about your work in California.
Thank you.
Any other last questions or comments before we wrap up? Really appreciate the discussion and folks' feedback and comments today. All right, well, if anything comes up, feel free to email us, or you'll have more opportunities for comment and feedback at our next meeting as well. And so, Gabby, I'll pass it back to you if that's okay.
Absolutely. Thank you so much, Amy and Sheethel. That was a great overview, and I think a very rich discussion. As always, we are very thankful for everyone's expertise of making this a collaborative process. So as mentioned, we'll kind of just wrap up with next steps and homework for the group. If you were unable to provide feedback during today's call, we really appreciate the live feedback, so we can dig a little deeper and get to the bottom of some of the suggestions. But we do offer the option that you can actually write in within the Word document your comments, revisions, additions on use case 3 components that Sheila just went over. You can send your revisions to myself, we compile them, and as you have seen in our meetings, we provide a summary of themes and how we plan to address them. For anything that we need to follow up with, we'll be reaching out directly to you if there's anything that we need clarification on. But that's really, for us, it's a good process for us to get those detailed notes from all of you. As it relates to submitting additional personas, Amy alluded to this earlier in the call. We encourage all work group members to support our use case package by submitting additional personas that might come into play as for our story. So we mentioned a community health worker being a persona that it's really crucial in this initiative of actually doing the legwork and supporting data collection. So we love to add that to our use case package as an appendix. In order to do so, we kindly ask workgroup members to download a use case persona worksheet. It's really just a way to collect the information from you in terms of the name, their role, so we can add those details into our package. You can rename it with your name so we keep track of how many submissions. We haven't received any as of the past 2 weeks. We did have 4 personas, and those have been posted on our document pages. Because all of this will be compiled into one use case package, we do kindly ask you to submit any worksheets by July 18. That will allow us enough time to put them all together to share in our last meeting on July 27. For some of you who are very familiar with the HL7 and Fire Connectathon community, the CMS, the Centers for Medicaid and Medicaid Services, is hosting a free Fire Connectathon on July 19 and 21st, so right around the corner. Registration for the event is actually, the deadline is actually tomorrow. There are many roles there if you're looking to test either your data integrator or any type of a tool. We really encourage you to join the Gravity Project track. If you have a technology solution to test, or if you would like to be an observer, there's also that option there. And thank you, Sarah, she put in the chat the link that you see here. So we encourage everyone, this is the 3rd CMS Connectathon, and it only happens once a year. So feel to take this opportunity if you're able to. And we'll pause here and see if there are any questions or any closing thoughts. All right, since we do have just a minute or so, I want to ensure that for some of you that are new to the work group, really our Confluence page is the way to get all of the information, especially if you're having some email issues. I'll put the link in the chat just now too. It really is a house for all of the information that we're reviewing with you today in terms of how to submit homework. As you can see here, follow-up from today is to please review the use case 3 components. As you can see here, you can download it and add your comments and send it via email to me. The optional homework is to download that persona's worksheet. We give you an example and also a description of what we're looking for in order to compile all of them together. And that will be part of our final deliverable, which is the use case package. Within 2 business days of our call, you will see in this section here, the slides, the recording, and any revisions of materials that were covered during the call. As you can see here, it goes all the way back to our previous, and then our project charter and project documents are available there, and you can see our timeline, project charter, as well as our business case, which was something that we mentioned earlier today, and the number of personas that have already been submitted are here for everyone's awareness. Okay, without further ado, I'll wrap us up and again, encourage you to join as a committed member of other interested party if you haven't done so. If there are any questions or follow-ups, you can contact myself, Gabriela, Svena, or Sarah. We'll be happy to assist you. And we have Kyla Davis, who is our CDC point of contact. And without further ado, we'll give you back your time. Thank you again for participating in this national consensus building process. We appreciate all the input.
Thank you.
Thanks, everyone.
Thank you. Take care.
Happy 4th.
Thank you.
That's right. Have a good holiday.